not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He, got his wrist pain by doing over-aggressive high fives to his buddies.
Let's bring it in. It's showtime, right?
All right, welcome to the Emergency Ultrasound Podcast. Mike Mallon here again with Matt Dawson. Today we're going to talk about wall motion and segmental wall motion abnormalities.
Wow, in fuego.
In fuego. So it's pretty cool to be able to do some echocardiography and actually see wall motion abnormalities, because you can actually sort of find the cardiac coronary distribution that's down and either try to match it with your EKG findings or increase your concern about your patient, maybe even push the cardiologist to get an emergent echo on them or just take them to the cath lab. So let's talk a little bit about this. The literature in the echo literature at least is pretty good about this stuff.
So wait a second. I'm already getting an EKG, enzymes, chest x-ray, all this other stuff on these chest pain patients, and now you're telling me that I should roll the ultrasound machine in there and take a look at their hearts.
Yeah.
Why?
Because you can see things that you're not going to see on EKG, and you're not going to get on your first troponin.
Well, yeah, but 6 hours later I'm going to have it on my troponin, so why should I care? Oh, wait, time is muscle. Is that what
Time is muscle. I think I've heard that before.
Okay.
Yeah.
Maybe that's... Okay.
Maybe that's something to think about.
All right, now I get it.
Okay.
Go ahead.
So the echo literature is pretty decent, and by decent I mean pretty awesome. So segmental wall motion abnormalities in acute chest pain patients, like 90 to 95% of them were found to have segmental wall motion abnormalities if they had a transmural infarction, and 80 to 90% were found to have segmental wall motion abnormalities if they had subendocardial. And this is not stress testing. This is baseline echo, like performed emergently when a patient has acute chest pain. And then if you look at the specificity, it's like 80 to 90%.
So that's pretty cool. I mean, the patients that are real, that you actually do want to get to the cath lab, that's a pretty good bunch of them that you're going to see something going on, and maybe it will affect.
Yeah, I mean, I think, so subendocardial, if you consider those, more than likely you're patients that have fairly normal EKGs, or at least, non-diagnostic EKGs. I mean, what does a non-diagnostic EKG get you? But then you find like 80 to 90% of them have segmental wall motion abnormalities. That's a pretty high number.
That's pretty awesome. However, I know I can't get an echo in most of the emergency departments that I work at, so I think you were suggesting that maybe I actually do the echo on these patients. Is that what you were suggesting?
I might suggest that.
Well, is there any actual literature to support that I can actually do it? Obviously, in the echo lab, they can do an echo.
Right. No, so funny you asked, Matt. So it turns out that there was recently a study published where they basically took 35 emergency medicine docs and gave them 30 minutes of training on segmental wall motion abnormalities, just like a quick module, sort of a didactic session, just going over this is normal, this isn't normal, this is an LAD lesion, this is normal, and they gave them a test, and they gave them a sort of a similar test. Obviously it wasn't the same questions, but their pre-test, they had 67% accuracy, and then their post-test, they had 87% accuracy on diagnosing ultrasounds that show segmental wall motion abnormalities. And the thing that I find interesting about this is not only is 87% pretty decent, 67% is not too shabby either. So it's kind of interesting. You take docs of all different walks of life who have some or none ultrasound training, and they still get 67% of these right. Like, that tells me this stuff must be pretty easy.
Yeah, no, I mean, this just goes along with we always say ultrasound is cheating. I mean, somebody comes in as chest pain, we have no idea what they have. We have a pretty low roll-in rate nowadays in the emergency department, but you can actually take a look in and cheat.
Yeah.
It makes your job a lot easier.
It potentially could. So should we try to make it a little bit easier?
Teach me how.
Let's do it. Let's get right into it. So we're going to basically go through this pretty quick, I think, and I think that's just because it's really not that complicated, and I don't want to just destroy the point. But we're going to start off with parasternal short axis, because this is the one axis of the heart where we're in a different plane than we are with all of our other windows. So the parasternal short axis starts off with a probe in the third to fourth intercostal space, just to the left of the sternum, with the probe marker pointed towards the patient's left shoulder, and you are getting a short axis of the heart. Every other image that we get, every other view that we get, is a long axis of the heart. Okay, so the short axis slices through the shorter axis of the heart, and it goes through the right ventricle first. If you look down here on the bottom right, Matt, there's the right ventricle is the first thing that the ultrasound goes through, and then you see a very muscular, circular left ventricle. Now this image is a normal parasternal short axis.
Is there a fish in that heart?
Yeah, there is actually a fish in the heart. So nice to point out. That's the mitral valve right there in the center that's flapping open. So that's the fish mouth view we talk about sometimes. And this shows good squeezing of that left ventricle. Everything's squeezing toward a central point, which you would expect. And the muscle itself is actually thickening during systole, which is what we're really looking for, is the thickening of the muscle, even more than the movement itself. So we can break that short axis into different segments, and this is what we mean by segments when we say segmental wall motion abnormalities. So the heart is actually broken up into 17 segments. I think that might be a little bit of overkill for an emergency physician, but the different segments are related to the coronary artery distribution. And just real quick here, segments are broken up into the anterior septum, which is right here. So that's the anterior part of the septum. The inferior septum, which is right here, that's the inferior portion, right? The actual inferior heart, which is down here, and then you go inferior lateral, anterior lateral, and then anterior all the way up here in the front. And then we can actually look at the different windows as they correspond to the short axis. So here the long axis runs through the anterior septum and then through the lateral wall. The 2-chamber runs through the anterior wall and the inferior wall, and then the 4-chamber runs through the anterior lateral and the inferior septal walls. Now, there's a lot of noise going on there. What does all that mean? Well, so here's an example of it going through the actual image of the heart, and then the heart overlaid on top of it. The important thing is here. This is the important thing. The LAD tends to supply the anterior septum and the anterior wall. Sometimes a little bit of the inferior septum, and then the LAD always supplies the apex. Okay, and then next the circumflex supplies the lateral wall, and so definitely the anterior lateral wall and the majority of the inferior lateral wall, and then the RCA pretty much supplies a little bit of the inferior septum, the inferior wall, and a little bit of the inferior lateral wall. So there's always some overlap when it comes to this stuff, but it's nice to know the generalizations. The generalizations are the LAD is anterior, the circumflex is lateral, and the RCA is inferior.
So is the cardiologist not going to come down if I call them and I'm not able to tell them exactly what's not squeezing well?
No, I mean, I think that, so, I mean, granted, some of this might be a little bit more than some people want to know, which is fine. I'm okay with that. I've accepted that. I've come to terms with it. I've moved on. And now
you sound angry that I asked you that question. I'm sorry.
No, it's okay. No, it's fine. So I think that granted, this is a little much, but I think it becomes important when you're talking about patients that have known coronary artery disease in the past, or prior MIs, or have been known to have certain wall motion abnormalities. I mean, in that case, you need to know what you're looking at and what's what, so that you know whether is this old or is this brand new. Is this their old LAD MI that they had 10 years ago, or is this something new that they need to go to the cath lab for emergently? So I think that it does become important when you start talking about the more complicated patients. Clearly, if you've got a 50-year-old guy with no history of coronary artery disease and anything looks abnormal, you're done, right?
But the cath lab.
Right, and how many patients do you have like that?
I had 4 yesterday.
Okay, great. Thanks. So clearly, not everybody is not
many.
everybody.
They usually have a strong history.
Not everybody is your young, healthy person who's having their primary lesion. So it's nice to be able to look at this and know what's what.
So you're telling me I might actually have to think about some of this.
I might. All right, so here we go. So this is the actual, this is an actual normal parasternal short axis, and now we're looking at the coronary artery distribution. So here's LAD. See how it hits that anterior wall and the anterior septal wall there. So this is anterior septal, and then over here is sort of anterior lateral. Now we add in the RCA. The RCA is going to hit your inferior wall, which is right here, and then sort of your inferior septum, which is right here. And then we add circumflex, which is over on this side. The circumflex hits mostly the lateral wall, the anterior and inferior lateral wall here. Okay? Good. Okay, so here we are with the apical 4-chamber view. So this is the view that's obtained by putting the probe at the point of maximal impulse and pointing the probe pretty much towards the patient's right shoulder. You're basically going to skirt the anterior chest with the the ultrasound beam, and you're going to want your probe marker pointed towards the patient's back or towards their shoulder. And what we get is we get a 4-chamber view. The view looks at the apex, where your apex is sort of your acoustic window here, and you can break the LV into apical, mid, and basal sections if you really want to. And really the only purpose of doing that is just knowing that the LAD tends to supply the apex more than any other coronary artery. So then we can look at how that 4-chamber slices through the short axis view, and you can see here that the 4-chamber is going to go through the inferior septum and the anterior lateral wall, just like there you can see it's outlined. So through inferior septum and anterior lateral wall. And then we can look at the coronary artery distribution here and see that LAD hits the apex, RCA is going to hit your inferior septum, and circumflex is going to hit the anterior lateral wall. Make sense?
Yep.
All right, so here's a normal apical 4-chamber view. We're looking at the inferior septum there and the anterior lateral wall, and we can overlay it to see what it should look like and what it ends up looking like in real life. All right, now to switch to the 2-chamber view, you keep the probe in the exact same place, pointed in the exact same direction, except you twist it. So now the probe marker is pointed up towards the patient's head. So it's about a 90-degree twist of the probe without any turning, no tilting, nothing else. Okay, and that gives you the apical 2-chamber view, which honestly, Matt, I don't talk about very much, just because I don't really use it that much in echocardiography, unless I'm really worried about the walls themselves. And what it does is it gives you the anterior and inferior walls. So here we see the 2-chamber view running through the anterior wall and then through the inferior wall. So this is a nice way to get a view of the RCA distribution from an apical window, and of course the LAD distribution. So you get a really good shot of the entire anterior portion of the heart. So basically that whole right side here is all LAD all the way up to the apex, and then when you get back onto the green side on the left, you're basically getting the inferior wall. Unfortunately, it's not green on the ultrasound machine itself. It'd be nice. It'd be nice if it was if the walls had colors on them on the ultrasound machine. That'd be awesome. So yeah, so that's RCA. So this is LAD and RCA distributions. All right, and here's the live version: anterior inferior wall. And last but not least is the long axis view. So you can get the long axis from either the parasternal window or from the apical window. This is a 2D diagram of the parasternal window, and here looking to your left, we can see that it slices through the anterior septum and through the inferior lateral or anterior lateral walls. And what that means basically to us is that you're going to be getting a LAD and a circumflex distribution through those two particular walls. Here's a live image of that. We see anterior septum up to the top and inferior lateral to the bottom. So that means that that's LAD up on top at anterior septal portion, and the inferior lateral portion is supplied by the circumflex. All right, so kinesis. So normal, it means that you are thickening more than 30%. Hypokinetic means that you're not quite thickening 30%, but you're thickening some. You can be severely hypokinetic if you're thickening less than 10%. Then akinetic is, of course, no thickening at all, and dyskinetic means that you've got outward motion, so that's kind of ballooning. So let's do some cases.
All right.
All right, Matt, what window are we looking at here?
Parasternal long.
Nice. And the parasternal long window is obtained by putting the probe in the third or fourth intercostal space with the probe marker towards the patient's right shoulder. And what do you see?
I see right ventricle, then left ventricle. I see a left ventricle that is not squeezing all that well.
So Matt's talking about this area right in here, and you're saying you don't feel like this left ventricle here is squeezing very well.
No, I see poor function.
Why would you tell me that you see poor function?
I see an aortic and a mitral valve that are not opening appropriately.
So here, like the anterior leaflet of the mitral valve right here, you're saying that's not coming up and touching the septum like you would want it to.
That's not what I said, but yes.
Okay, that's what you're getting at, though. You're saying that anterior leaflet of the mitral
Words
valve,
in my mouth.
that anterior leaflet of the mitral valve isn't flapping enough and not getting close enough to that septum, and that's actually a pretty good indicator that somebody's got decreased cardiac function. So I agree with you. I think that's probably true. That just doesn't look like it's squeezing right. Can we look at this left ventricle and say, one portion of it seems to be squeezing less than another portion?
I think yes. That portion on the back side at the bottom of the screen.
Okay, down at the bottom of the screen.
The green part.
The green part. I'm not sure that was actually green, but maybe it was green. Maybe it was yellow.
Yeah, greenish yellow.
Greenish yellow. Okay, great. So you're telling me the septum looks good.
Septum LAD distribution looks pretty good.
Nice. I like it when you start throwing coronary arteries at me. So yeah, I agree. The LAD distribution here looks like it's squeezing, it's moving. There's some function there. This looks funky. It looks, I mean, not only does it look a little thick, right, but it also looks like it's not really doing anything at all. It's not moving.
Mm-hmm.
So this is what coronary artery?
RCA.
It's a little bit of sometimes RCA. It's usually circumflex. Yes, yeah. Exactly. So it's usually circumflex. So that's usually the inferior lateral wall. Remember how we said lateral is usually circumflex. Sometimes you can have a little bit of RCA in here, and you were actually right on there with yellow-green. So if you just called the cardiologist and say the yellow-green section is not functioning correctly, then I'm sure they would know what you meant because they've probably listened to this podcast lots of times. So anterior septum anterior septal portion looks like it's functioning well, but here the inferior lateral is not doing what we want it to do, right? So here we see LAD is okay, circumflex sucks. So you take that, you compare it with your EKG, you look at your trope, you decide, does this patient meet somebody who I would expect to have a circumflex lesion, and decide whether you want to jump on it and get crazy and give them heparin and call your cardiologist, or how you want to handle it. All right, case 2. What window are we looking at here, Matt?
Looks like an apical 4-chamber.
Awesome. So this is an apical 4-chamber window, and this is obtained by putting the probe at the point of maximal impulse. And what would you say about the function of this apical 4-chamber, my friend?
It doesn't look horrible. The left ventricle is squeezing, but not all of it is squeezing. It looks to me like the apex is not working.
Okay, so what you're saying to me is you're saying this mitral valve is opening really well and almost abutting that septum there, telling me that the actual ejection fraction is probably decent, but something's weird, huh?
Apex is
Something's
lazy.
weird. So we're gonna go in order here, starting with here the basal septum. How does that look?
Pretty good.
Okay, so we think that's squeezing all right. How about the distal septum? What do we think about this portion here?
It's still squeezing, but it's getting lazier.
Laziness. And up in here, what do we think about
squeezing.
that? Sucky. Okay. And then down over on this side, what do we think about this stuff over here?
Not great and better.
Not great and then better. Okay. All right. I like what we were thinking. So we could either call the cardiologist and say all that, or we could say, hi, this is Dr. Dawson. I'm calling to tell you that I've got a patient with a blah, blah, blah lesion based on bedside echocardiography.
LAD.
All right, awesome. So this looks like an LAD lesion based on the fact that the apex is what's really down. Now, there might be a little bit of hypokinesis down on this side here, which would be sort of our circumflex distribution. But man, I'm telling you, this basal septum here, which is RCA, this looks awesome.
It's getting after it.
Yeah, RCA is kicking butt, man. But LAD is way down and not looking happy. What's that funkiness up in there?
I'd say maybe a clot.
Yeah, so that's a funky clot chilling out in the LAD distribution. So what happens is when you get that part of your heart that's so dead, or the myocardium has been down for so long that there's not any squeeze, you actually get like hardly any blood flow in that particular area, and the blood will just sit there and it'll clot off, and that's how people get apical thrombi. It's very, very rare to get an apical thrombus without some sort of coronary artery
did you see that?
lesion.
I think I just saw a little part shoot off into the...
just shot right off into the carotid. Yeah, they just stroked right there on that echo.
Wow,
it's terrible. All right, so interesting finding, not necessarily something you want to see on somebody or see in one of your patients. And here we're just showing the apex all the way to the top here, which is typically LAD distribution. Voila. All right, case 3. So to round it out here, this is our last case, Matt. So you're going to be off the hot seat soon. So what are we looking at now?
Is that like a apical 3.5 chamber view?
This is an apical and 3 3/4 chamber view.
Yeah, what is this?
I love it when you make fun of the echo. So this is actually an apical long axis window. So this is something that you probably don't really see that much unless you're just sort of messing around with your apical window trying to find a four-chamber. But what happens is you're seeing sort of the LV here, right? And then this is the left ventricular outflow tract, and I know that because I see the aortic valve right there. Do you see that aortic valve right there? And then of course this is the mitral valve, and this is the left atrium. So if you imagine, this is just kind of like an end-on-end parasternal long axis view. You're seeing the exact same stuff, it's just you're seeing it from a different direction. You're looking at the parasternal axis view from the apex instead of looking at it from the right ventricle. Make sense?
Got it.
So, and then here, this is actually our view right over here. Okay, so all the walls on this view are, even though it looks weird, are the same as your long axis window. So now we know what we're looking at. We're looking at an apical long axis. What do we think about the function here?
Well, the apex looks pretty crappy.
Okay.
It's just not working at all. I mean, it almost looks like it's ballooned.
Mm-hmm.
So LAD distribution there.
Okay.
And then is that your lateral or more anterior wall? What is it? Is it your lateral wall that's...
You're talking about right over here?
Yeah, that's not squeezing very well.
Yeah, so this would be actually your inferior wall, right?
That's
Your
what I say.
inferior lateral.
Yeah.
Yeah. Good job. So we're looking at, so this is actually anterior septum here, right? So this is LAD distribution. So tell me, Matt, why would this part of the LAD distribution work okay, but this part would not?
Because it's more distal occlusion.
Perfect. Yeah, actually, that's an awesome answer. So basically, you've got a distal occlusion of the LAD, so it's occluded far enough down that you're getting blood flow to the proximal septum here. But as you get to distal septum and to apex, you're not getting blood flow anymore. So this is sort of like a midway LAD lesion. I don't know. It's not quite distal because you're still getting some of the septum out here, but it's definitely not a proximal LAD lesion. So that's why you're getting some function in the septum here, but nothing to the apex. And then over here, when we're talking about the inferior lateral wall, which coronary distribution is that?
Our circumflex.
Circumflex, awesome, perfect. So this is the circumflex area over here, and you can see that maybe there's a little bit of function right here towards the base, but up in here it's pretty crappy, if anything. So this person have some proximal LAD working, but everything else is pretty much out, and it's just kind of, I mean, it's almost ballooning out here towards the apex, huh? So this is a little bit of dyskinesis. We got dyskinesis over here, and at least hypokinesis, maybe akinesis over there. I just like saying like kinesis words because I think they sound like they make me sound intelligent.
Akinesis, dyskinesis.
You can talk about that all day long, but in any case, this is your LAD, which is down. All right, Matt. So next time you have a patient come in with a STEMI, what are you gonna do?
So in the past, if it's been a STEMI, then I call the cardiologist. They go to the cath lab.
Okay, you then just try the Dawson technique of giving 2 liters, and if they're not better, tube them?
No, I think if it says STEMI on the EKG, I'll go ahead and call cardiology.
Okay, so if it prints out STEMI on the EKG, then you'll give them a call.
Yeah, no, seriously though, I mean, everybody, of course, knows what to do with the STEMI patient. But I actually really like this. This is kind of exciting to me, I think, because we have those patients that, of course, the EKG is not very helpful, but we're pretty sure we've seen enough patients with chest pain that we think this is the real deal. And you don't want to wait for an hour for the troponin or even the 15 or 20 minutes for the troponin. And if they've just started with the chest pain, the first troponin, of course, may not be elevated. Then you're waiting even more hours. This is pretty exciting that I've got another tool that I can walk in quickly on the patient that I'm really worried about and take a look, and in a matter of 1 or 2 minutes see if there is a wall motion abnormality. You told me that 80 to 90% of these patients that have real disease will have a wall motion abnormality. This is pretty cool that I could get those patients to the cath lab quicker.
Yeah, all you got to do is use it. And I think hopefully these cases have shown us that it's really not that hard to use. I mean, it's pretty obvious.
Seems like it, yeah.
It might not be nearly as important as we're implying that you know which wall is which and all of that. But if you can kind of get the idea of what the coronary artery distributions are, that's 90% of the battle.
So I'm going to be honest with you. When I do this, I don't usually remember. Actually, I don't ever remember really what lesions go with what areas of the wall. But if I see an abnormality, it's a pretty quick and easy thing to go look that up. You can go ahead and call the cardiologist. If they call back right away, you tell them we've got a new wall motion abnormality. If they don't call back, then you've got time to actually look it up and sound really smart and tell them where the lesion is. So it's not a big deal when you actually have this patient. It's not something that you can't look up quickly.
Yeah, I mean, I think mostly, the whole like inferior lateral, anterior lateral, all that crap. I don't really remember that stuff. I just kind of have an idea of where the coronary artery distributions are and just use that as my guide. And I think that's worked out great for me in the past. So
awesome. I wish I had a shift like right now so I could do this. I'm so excited.
I'm sure you do. All right, guys. Thanks for listening. We'll be coming back at you soon.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.